My name is Kersee Worden, and today my group and I will be discussing rotator cuff injuries in the older adult population for our research project. I'll be starting out by talking about the anatomy and physiology of the rotator cuff, following with the typical range of motion of the shoulder joint. The reason we decided to go with the elderly population is due to the statistical prevalence that age and rotator cuff tears go hand in hand. Rotator cuff tears are very common among the geriatric population. According to Gary Michael, he did a study on the rotator cuff tears in the elderly population, and he discovered that advanced age is related to having a higher incident rate in encountering rotator cuff tears. In adults 80 years of older, they are 80% more prone to rotator cuff tears, and they tend to be more massive tears, which are less receptive to being repaired by surgery. In order to discuss the disordered shoulder, we will have to have a general understanding of the typical anatomy of the rotator cuff and how they move. I first want to clarify what the rotator cuff is and why it is important for it to be in good condition. The general definition of the rotator cuff is provided by the Mayo Clinic. It states the rotator cuff is a group of muscles and tendons that surround the shoulder joint, keeping the head of the humerus firmly within the shallow socket of the shoulder/glenoid cavity. The rotator cuff is important in aiding you to perform your daily and enjoyable activities, such as reaching for an item on the top shelf, throwing a ball with your friends, or going swimming on a nice summer day. The rotator cuff is made up of four muscles, the supraspinatus, subscapularis, infraspinatus, and teres minor. These muscles will arise from the scapula and they will insert into the humerus. During arm movements, rotator cuff muscles will contract and they'll prevent the head of the humerus from sliding, which allows for full range of motion and stability. Next, I'll be talking about the primary biomechanical role of the rotator cuff, and it is to stabilize the glenohumeral joint by compressing the humeral head against the glenoid. And you can see it in the picture listed to the right. It looks like the muscles are tugging on that humerus to keep it into that socket. Now moving on to discuss each individual muscle and what their important function is. One easy way to remember the muscles of the rotator cuff is by the acronym SIDS. First off, I'll be talking about the supraspinatus. The supraspinatus is located on the superior aspect of the scapula and the humerus. It originates in the medial two-thirds of the supraspinosa fossa of the scapula, and then it will pass over the glenohumeral joint. It will insert into the greater tuberosity of the humerus. The supraspinatus' main muscle action is abduction. It is also the most common muscle that is injured within the rotator cuff. The main thing the supraspinatus helps your humerus do is to keep it in place and keeps your upper arm stable. And it's also very necessary for the first 0 to 30 degrees of abduction motion. Next, I'll be talking about the infraspinatus. The infraspinatus is located on the posterior aspect of the scapula. It originates in the infraspinosus fossa of the scapula, and it inserts into the greater tuberosity of the humerus, which is immediately below the supraspinatus. The main muscle action for the infraspinatus is the external rotation and horizontal abduction. It is also a very powerful lateral rotator of the humerus, and it's the main muscle that helps you rotate and extend your shoulders. Next, I'll be talking about the teres minor. The teres minor sits along the posterior part of the scapula, inferiorly to the infraspinatus and superiorly to the teres major. It originates in the lateral border of the scapula and inserts into the greater tuberosity of the humerus, right below the infraspinatus tendon. The muscle action for the teres minor is external rotation. It is the smallest rotator cuff muscle, and its main job is to assist with rotation of the arm away from the body. Lastly, I'll be talking about the subscapularis muscle. The subscapularis muscle is a large triangular shape, and it is the largest and strongest muscle within the rotator cuff. It originates in the anterior surface of the subscapular fossa, and it inserts into the lesser tubercle of the humerus. Its main muscle action is internal rotation, abduction, and extension. It also prevents the anterior dislocation of the humerus during abduction and immediately rotates the humerus. This holds your upper arm bone and your shoulder blade and helps you rotate your arm and hold it straight out and lower it. Since the rotator cuff muscles aren't very large muscles, they have to have increased muscular endurance and increased muscular strength for them to work properly and not cause any injuries. Lastly, I'm going to be talking about the typical range of motion of the shoulder. It is important to obtain good range of motion in your shoulder because if your range of motion isn't up to the recommended degrees, it can cause an injury and making performing activities of daily living very difficult. Determining the specific range of motion for the glenohumeral joint is sometimes very difficult because the shoulder girdle assists in the movement, so there's no primary movement in those times. In order to see the shoulder's range of motion, there is testing that can be performed, and the testing will be measured by the use of a goniometer, pictured to the right. When testing range of motion of the shoulder, it needs to be tested in different directions, so you're able to see like the deformities, if there are any. If movement in one specific direction is painful or lacking mobility, this can signify a tear and impingement of the shoulder. I'll be explaining 6 of the range of motion tests, but there are many more that can be performed. First, I would like to show you what forward flexion is. Here's a video to properly show you what forward flexion is. You're going to have your patient start with their arms by their sides, and you'll ask them to raise it fully straight in front of them as high as they can go, with their thumbs pointing upwards. This test will be moving the humerus straight anteriorly. The typical degrees for forward flexion, if the shoulder girdle is prevented from moving, would be around 90 to 100, and if the shoulder joint is free to move, it would be around 140 to 150. Next, I'll be showing you backward extension. Here's an example of backward extension. You'll have the patient start with their arms by their sides, with the palm of their hands facing forward, with the arms extended, pushing them backwards. This test would be moving the humerus straight posteriorly. The typical degrees for backward extension would be somewhere around 40 to 60 degrees. Next, I'll be talking about abduction. Here's an example of abduction. You'll have the patient start with their arms by their sides and ask them to raise their arms laterally until they can reach their hands above their heads. The examiner will support the scapula during this exam, and this will cause it to be a passive test because of the examiner assisting. The movement would be an upward lateral movement of the humerus out turned to the side. The typical degrees for abduction, if the shoulder girdle is prevented from moving, would be around 90 to 100. And the typical range of motion, if the shoulder joint is free to move, would be around 170 to 180. Next, I'll be showing you crossbody abduction. Here's a video to show you crossbody abduction. You'll have the patient flex an upper extremity forward to 90 degrees. From this position, you'll ask the patient to abduct their shoulder by moving the arm horizontally to the other side. And you'll want to make sure to take only one side at a time. The typical average degrees for crossbody abduction would be around 116 degrees. Next, I'll be talking about external rotation. Here's an example of external rotation. You have the patient flex at the elbow 90 degrees with the arms attached to the trunk and the palms supinated. Then have the patient externally rotate the shoulder by bringing the forearms laterally. The typical degrees for this rotation would be 90 or 70 degrees to 90 degrees. The last range of motion test I wanted to talk about is a high posterior reach with the thumb, as seen in this video. The back of the hand will be placed on the lower back, and the patient is asked to reach as high as they can along the spine. The typical highest level a patient can reach will be marked. And you can see it would be around thoracic vertebrae 4 and thoracic vertebrae 8, which is marked by the red lines pictured to the right. The test I just went over were to test the shoulder's range of motion to see if there's any weakness, pain, or lack of mobility in a specific area. If there's a lack of range of motion during a specific test, there are other tests that are specifically to test the muscles of the rotator cuff. The first test I wanted to go over is the lift-off test. The lift-off test, here's an example. It can work. There it goes. Here's a lift-off test. This would be considered a negative lift-off test. So the reason that this is a good test for scapularis is because when your hand is on your lower back, in this position, it puts the greatest amount of stress on this muscle. Your patient will be touching the lower back with their arm fully extended and internally rotated. This test will be judged positive if you're unable to lift your hand off of your back because it shows weakness in the subscapularis. Next, I'll be talking about the empty can test / Jobs test. This is the test of supraspinatus. This test is performed by having the patient raise their arms by 90 degrees in the subscapular plane, and then you'll have them internally rotate their arms by having their thumbs face the ground. They'll be acting like they're pouring out a can. Here's an example. And also during this test, the examiner can apply downward pressure to the patient's arms, and they will need to resist that pressure. This will be considered a passive test as well. This test would be considered positive if weakness to the resistance and with the arms at 90 degrees of abduction when compared to angled forward at 30 degrees. Lastly, I'll be talking about the teres minor and infraspinatus test. This would be called the Horns-Blower sign test. As this video is going, I'll be explaining it. So you're going to have your patient sit down to perform this test. And have the patient's arm at 90 degrees of abduction in the subscapular plane with the elbows flexed at 90 degrees. The examiner will have the patient's arm supported at the elbow and they'll have their other hand on the patient's hand. The patient then attempts to externally rotate their forearm against the resistance of the examiner's hand, and if they cannot externally rotate, it will be considered a positive test. As previously mentioned, the rotator cuff muscles are for performing overhead activities such as throwing, swimming, combing your hair, reaching things on a top shelf. If these activities are performed with poor technique, it will lead to failure of the rotator cuff stabilizing humerus. Now that the anatomy and physiology of the rotator cuff has been established, Kaitlyn Springer will discuss the mechanisms of an injury due to degenerative tears of the rotator cuff that are common among older adults.
Hello, my name is Kaitlyn Springer, and as Kersee mentioned, I will be discussing degenerative tears of the rotator cuff in the older adult population. Not only are tears of this nature important to study due to their prevalence and proportional increase with age, as Kersee formerly established, but they also have clinical relevance because muscle degeneration is associated with decreased clinical outcomes and slower tendon healing. Degenerative tears may or may not be symptomatic or pain-inducing, but will worsen over time without intervention. When discussing the etiology of rotator cuff tears that are degenerative, it is helpful to explore the changes that occur over time within its muscles and tendons in order to create an overall musculoskeletal environment that is prone to deterioration. Although repetitive overhead motions can lead the degenerative process in the shoulder, there's not just one singular movement that causes degenerative rotator cuff tears. Rather, it is the sum of tissue changes that occur with aging alongside cumulative wear and tear. As individuals age into later adulthood, the frequency and intensity of their physical activity tends to decrease. So as the muscles of the rotator cuff are used a lot less, they decrease in size and in strength in a process called disuse atrophy. As individuals age into later adulthood, they also may experience mechanical unloading, which refers to a decrease or lack of power and force expended by the muscles due to low levels of movement against resistance. And this could mean resistance against gravity, so not moving very much just in normal motions with the arm, which would just have the pull of gravity, or not doing many things with external resistance, which could look like traditional resistance training with weights, or just carrying objects around the house. So that may be reduced over time, which would contribute to the mechanical unloading. And this mechanical unloading is also often associated with prolonged inactivity, such as bed rest, and it may further contribute to the disuse atrophy. Within the muscles of the rotator cuff, as the muscles become smaller, thinner, and weaker, they begin to retract and fat will begin to deposit abnormally in the shoulder. And we will explore both of these in the images in the next slides. Just as the motion of shoulder retraction refers to the scapula moving medially toward the spinal column, pathological retraction of the rotator cuff involves muscles and tendons shifting away from their normal insertion and moving towards the midline. So this image shown is depicting 3 stages of retraction of the supraspinatus muscle as it gradually slips from its normal insertion, which is on the greater tubercle of the humerus, and moving along the spine of the scapula towards its medial border as it moves from stage 1 to 3. Not only does the muscle shrink and change location during degeneration, but the muscle tissue that does remain often changes in its composition as excessive fat begins to deposit. And this is a process called fatty infiltration. As the muscles atrophy, they also undergo remodeling at both the muscle fiber and tissue level. In the space where muscle used to reside in the rotator cuff, fat begins to accumulate there. Adipose tissue is not contractile like muscle tissue is, so it disrupts the movement efficiency and force capacity of the rotator cuff. This MRI shown here is depicting the rotator cuff from the sagittal plane view. So it's as if you had divided the body into left and right portions and then removed the arm out of the way so that you could look deep inside the shoulder girdle, as if you were standing perpendicular next to the person. So the white arch shown on the right of each picture is the posterior body surface and the skin covering the shoulder, and then the Y shape in the center with the is the scapula, the Y shape is the scapula, and the right branch of that Y is showing the bisected spine of the scapula, and then the dark gray that surrounds the Y shape represents the muscles of the rotator cuff, and then any of the little gray circles and streaks scattered within the dark gray are showing fat deposits. So in Fuchs stage 1, which is shown in the leftmost image, there are a moderate amount, Fuchs stage 1 represents a minimal or no fat deposited, whereas in stage 2, which is the middle image, that is where we have a moderate amount of fatty streaks within the muscle. But at this stage, there still is proportionally more muscle than fat. But in stage 3, in the right picture, there is severe fatty infiltration of the rotator cuff. And at this point, there is either equal amounts of muscle and fat or proportionally greater fat than there is muscle, which is a severe infiltration. So not only do the muscles undergo degenerative changes, but the tendons of the rotator cuff also undergo degeneration. In early degeneration, the tendons change at the minuscule microstructure level with tiny tears. But these add up over time into noticeable deficiencies in the whole tendon structure and function as it becomes less able to withstand stress. Ultimately, a rotator cuff tendon may tear completely and fail altogether, so it becomes unable to perform its mechanical role in transmitting the force produced by the rotator cuff muscles to their humerus bone to cause shoulder and arm movements. And depending on the tendon involved, moving the arm in directions and/or dynamically stabilizing the shoulder movements will be reduced or prohibited when damage occurs. Also, in response to the chronic degeneration occurring in the shoulder, inflammatory cells of the immune system will migrate, and that's in an attempt to facilitate healing. And then these immune cells will accumulate within the rotator cuff tendons.
And some authorities believe that these residing inflammatory cells send signals that modulate and control rotator cuff degeneration in a kind of autoimmune response. Degenerative tears can occur in any of the four muscles of the rotator cuff, but they frequently initiate in a specific region known as the rotator crescent. The rotator crescent is a half-moon shaped portion of the rotator cuff, and it's shown in the picture on the left. And it lies between the biceps tendon and the inferior Worden border of the infraspinatus tendon. And this crescent is bordered and outlined by the rotator cable, which is a thick bundle of fibrous tissue at the intersection of the glenohumeral and coracohumeral ligaments. This arched cable, which is shown by the dotted black line, is structured kind of like a suspension bridge is, and it acts to protect the more delicate crescent beneath from stress in the case of healthy shoulders. However, this area does not have a good blood supply and therefore does not heal well and thins progressively with age. This picture shown on the left is a photograph of a cadaver with the rotator cuff muscles lifted off of the head of the humerus to show the common location of degenerative tear initiation. So this is the junction between the insertions of the posterior portion of the supraspinatus and the anterior portion of the infraspinatus muscle at approximately 15 to 16 millimeters posterior to the biceps tendon. And this spot is particularly vulnerable and is where tears usually begin. And the picture represents this by the star shape in the center of the photo there. Because so many structural and functional changes are involved in the degenerative tears, and these changes occur cumulatively and progressively worsen over time, the rotator cuff is not likely to regenerate. This is not to say that the treatment interventions are not worthwhile, but rather that full restoration of the rotator cuff's typical functionality and mobility should not be expected when the tear starts in a degenerative nature. So after a degenerative tear is initiated, it will propagate and spread out in width and depth from that location. And if the degeneration becomes advanced and if the tear spreads and it surpasses what's considered a critical size threshold, then the rotator cuff will no longer be able to stabilize the position of the humeral head in its healthy position, and it will begin to migrate proximally. And this means that the head of the humerus will begin moving medially and crush inward on the glenoid cavity, which can dramatically disrupt the kinematics of the shoulder. Each individual muscle of the rotator cuff is playing an important role in the stabilization and movement of the glenohumeral joint, but they also act in synergy with the deltoid and other muscles to balance the forces as the shoulder moves through its range of motion. Therefore, damage in one rotator cuff muscle will also impair its ability to contribute to its muscular partnership, which then impairs movement and stability beyond just simply its own independent roles. This illustration shown is depicting a full thickness tear in the most commonly torn rotator cuff, which is a rotator cuff muscle, the supraspinatus. It also is displaying that important rotator cable from a different view underneath. And degenerative tears that progress to this stage are considered to be massive injuries, and they will likely cause noticeable changes that can be detected by abnormal results in range of motion tests like those that Kersee outlined, as well as deficits in functional testing. Shown here are my references utilized for both the informational content and images in this section. And next, Mary will be further describing a common type of rotator cuff injury to the tendons, which is impingement syndrome. As Kaitlyn mentioned, my name is Mary Walker, and I will be covering impingement syndrome today for my portion of this presentation. Covering impingement syndrome is relevant for our presentation pertaining to older adults because the incidence of shoulder impingement syndrome increases with age. Statistically speaking, peak incidence of shoulder impingement syndrome is within the sixth decade of life. To provide a good foundation for understanding the technical details surrounding shoulder impingement syndrome, it is important to first understand what shoulder impingement syndrome looks like from a general standpoint. The signs and symptoms of shoulder impingement syndrome commonly seen are pain with lifting arm, pain with lying on the affected side, pain located over lateral acromion with radiation to lateral to mid-humerus, and weakness during abduction and or external rotation on the affected side. And then lastly, tenderness with palpation over cord process of the affected arm. And I find it important to mention that often onset of shoulder impingement syndrome is a gradual occurrence. So individuals suffering from this diagnosis often can't identify a specific event that causes the experienced pain. In terms of a timeline, the pain can develop over weeks or months. There are four common types of shoulder impingement syndrome. Those types are anterior acromial impingement, posterior superior glenoid rim impingement, subcoracoid impingement, and suprascapular nerve impingement. The potential causes of each type differs. Beginning with anterior subacromial impingement, this is when tissues filling the subacromial space are trapped between the humeral head and the coracoacromial arch. Those soft tissues are the subacromial bursa, supraspinatus tendon, and biceps tendon. Posterior superior glenoid rim impingement is potentially caused by the inner fibers of the rotator cuff and fibers of the posterior superior labrum between the greater tuberosity and the posterior superior glenoid being compressed. Subcoracoid impingement is potentially caused by a posterior rise of the humerus in a plane of 30 degrees combined with internal rotation. Suprascapular nerve impingement is potentially caused by the intrusion of the suprascapular nerve. So you'll notice here that subacromial impingement is bolded, and that is because subacromial impingement is by far the most common type of impingement seen. And so for that reason, for the remainder of my portion of this presentation, I will be focusing solely on subacromial impingement. But before jumping into specifics, I wanted to appreciate how far we have come in terms of knowledge concerning impingement syndrome. So in 1934, a man with the last name of Worden determined that he thought rotator cuff lesions were caused by the rubbing of the humeral head and the acromion. Years later, in 1972, Charles Neer coined the term of impingement and became the first to establish many of the specifics surrounding subacromial impingement syndrome. Today, it is also important to mention that subacromial impingement syndrome has two different types of forms. So there are both primary and secondary forms. The primary form of impingement is when the impingement is caused by changes to the structure that mechanically narrow the subacromial space. The primary form of impingement can be from bony narrowing on the cranial side, which is also called outlet impingement, and bony malposition after a fracture of the greater tubercle, or an increase in the volume of the subacromial soft tissue on the caudal side, which is also known as non-outlet impingement. And the other form is secondary impingement, which results from the humeral head being uncentered, which leads to an abnormal placement of the humeral head that causes entrapment of soft tissues, which leads to pain. I do find it important to mention that there are two differing mechanisms proposed for the cause of subacromial impingement syndrome. So those are extrinsic and intrinsic mechanisms. There is the extrinsic mechanism that suggests that the impingement causes damage to the tendons. This is a traditional proposal that many still defend today. This is where the term of impingement came from. And then there is the intrinsic mechanism proposal that suggests the damage to the rotator cuff tendons leads to impingement. So within this proposal, the effects of the diagnosis would be due to microvascularity of the insertion of the supraspinatus tendon. Which of the two specific mechanisms that occur when one has this diagnosis, or if it's a combination of both, is currently being researched because people do argue in both directions. Within subacromial impingement syndrome, most commonly seen is external impingement. And external impingement is associated with inflammation and irritation of the structure within the subacromial space. So in an attempt to better understand external impingement, it is important to be able to associate that space with the anatomical features surrounding it. The acromion and the coracoacromial ligament are the anterior border, and the superior border is the acromioclavicular joint, which is also known as the AC joint, and the inferior border is the humeral head. So pictured here to the left, you can see the subacromial space and coracoacromial ligament, and to the right, you can see the supraspinatus tendon with a dashed arrow, and you can see the acromion where the asterisk is. Interestingly, the shape of the acromion is believed to potentially play a part in the genesis of external impingement syndrome. A study completed in 2013 found that a lateral acromion angle that is low or a lateral extension of the acromion that is large, those are associated with higher prevalence of impingement syndrome, as well as a higher prevalence of rotator cuff tears. Forward flexion, intra-rotation, shoulder abduction, and any normal shoulder girdle movement requires narrowing of the subacromial space. The space is normally 1.0 to 1.5 centimeters in width, and it narrows with the migration of the humeral head going superiorly. When the humeral head rises in this way, it approaches the anterior-inferior edge of the acromion, and if one is suffering from external subacromial shoulder impingement syndrome, the pain they are noticing is due to the humeral head applying a force that compresses to the rotator cuff, the subacromial bursa, or both. I must note that this assumption would fall underneath the extrinsic mechanism proposal, for this suggests that there is true impingement that causes the pain. It should also be noted that repetitive compression of the rotator cuff tendons are known to contribute to the narrowing of the subacromial space. With this being said, going back to our two mechanism proposals, it is currently not known if the damaged tendons cause impingement or if the smaller subacromial space causes the tendon inflammation. So the biomechanics mechanism that explains extrinsic subacromial impingement syndrome is simply based on the narrowing of the space leading to rotator cuff tendon compression. The compression can occur from the humeral head moving superiorly or the acromion moving inferiorly. Because of this, the rotator cuff muscle performance suffers. As seen in this photo, the arrow shows that due to contact between the humeral head and the acromion, there is impingement of the soft tissues, which causes pain. The biomechanics mechanism that explains intrinsic subacromial impingement syndrome is that there are tendon tears, partial or full thickness, that occur as a result of the degenerative process, as talked today by Kaitlyn today. As mentioned before, the intrinsic theory suggests the diagnosis is due to issues with the supraspinatus tendon, where the tendon inserts. There is an area that is avascular where a tear commonly occurs from, which would cause the pain. Again, there's uncertainty about which mechanism, intrinsic or extrinsic, or if both mechanisms play a role in impingement syndrome. I wanted to discuss some of the predisposing factors to subacromial impingement syndrome. You can see some predisposing factors listed here, beginning with an off shape of the acromion, an off orientation of the acromion, presence of osteophytes at the acromioclavicular joint, which is also known as the AC joint, ossification of the coracoacromial ligament, and also presence of os acromial. As an example, this picture includes a clavicle, you can see with the open arrow, and a low-lying acromion, which you can see with a solid arrow. An acromion that is low-lying would predispose someone to subacromial impingement syndrome due to the lessening space available for the subacromial anatomical features to comfortably reside. There are stages associated with subacromial impingement syndrome. These stages were discovered and called out by a man with the last name of Charles Neer, who we covered earlier in the presentation while the announcement was going off. In the first stage, stage one impingement is resulting from edema, hemorrhage, or both. This is often seen with overuse. Stage two is characterized by greater fibrosis and irreversible tendon changes. Stage 3 is associated with a rupture or tear of the tendon that may result from long-standing fibrosis. And it should be noted, again, that these stages lean towards the extrinsic mechanism proposal, which, although most traditional, has had some conflicting suggestions brought to it within the past few years. So as mentioned, there's much more research that needs to be done to confirm which of the two proposals are correct. And up here you can see some tests that are used to utilize to determine if an individual has subacromial impingement syndrome. So there is the Hawkins test, which runs positive if pain arises when the patient completes max internal rotation at 90 degrees with elbow flexion. This test highlights what occurs when the subacromial space between the greater tubercle and the coa acromial ligament is narrowed. There's also the near sign test, where one hand fixes on the scapula and the other hand rises and internally rotates the arm. And this causes the greater tubercle and the roof of the shoulder joint to make contact. There's also the Job test, which is where the individual will raise their arms in a frame of 90 degrees of abduction with 45 degrees of flexion in internal rotation. And then lastly, there is the painful arch test, which is that test will highlight any pain during abduction with an extended elbow in the scapular plane between 60 degrees and 120 degrees. So here are my references listed that I used to create this portion of the presentation. Moving forward, my teammate Dawson will conclude this presentation as well as provide insight on novel research on shoulder joint injuries.
Hello, my name is Dawson Russell. I will be covering the conclusion and novel research over the shoulder joint injuries. And then before I get into my presentation, I would like to provide a brief overview of what my fellow group members have talked about so far. First, Kersee, she talked about the anatomy and physiology over the rotator cuff. Second, Kaitlyn, she covered the degenerative rotator cuff. And third, Mary, she covered the impingement syndrome. And then next, when I get into is a picture of the shoulder anatomy. I'm just going to provide a brief overview, but I will be getting into the shoulder joint, which is made up of the collarbone, the shoulder blade, and the upper arm bone. And then now I'm going to get into other shoulder joint injuries. The first one is shoulder instability. This usually occurs when the lining of the joint ligaments becomes stretched or torn. This is usually caused when the head of the upper arm bone is forced out of the shoulder socket. It can either be partially or fully forced out. This can usually happen from overuse or sudden injury. This is usually caused in car accidents. Once it has been dislocated, there's a future chance of injury again because it's vulnerable, and then more than likely it will dislocate again in the future. Next is the frozen shoulder, also known as adhesive capsulitis. This has 3 stages. The first stage is freezing. You will slowly have more pain and stiffness in your shoulder. This usually lasts from 6 weeks to 9 months. Your range of motion in this stage will you lose it mostly. And then your pain, it will increase. And then stage 2 is the frozen stage. Your symptoms will improve, but your stiffness will worsen. And this will usually last from 4 to 6 months. This will make your daily activities hard to do. And then stage 3 is thawing, which your range of motion improves slowly, but completely return will take up to 6 months to 2 years. Frozen shoulder or adhesive capsulitis affects people in the ages of 40 to 60 mostly, and it occurs in women more than men. Next is arthritis. This is the inflammation of the shoulder, one or more joints in your shoulder. This will cause pain and stiffness. There is really nothing you can do to help cure arthritis. You can only manage it by staying active and taking over-the-counter medications. There is 5 major types that affect your shoulder. The first one is osteoarthritis, or the wear and tear. It usually affects the cartilage on your bones and just rubs away. Rheumatoid arthritis. This is the chronic disease. It usually affects multiple joints in your body, and it also is symmetrical, meaning that if it affects your right shoulder joint, it will affect your left shoulder joint. And the next is the post-traumatic arthritis. It usually occurs after a traumatic injury. And then next is rotator cuff arthropathy. This arthritis usually develops after a long-standing injury or a large tear in your rotator cuff. This damages the surface of your bones, and it could lead to being able not to be able to lift your arm from your side. And then continue on, avascular necrosis. This is a painful condition when the blood supply to the head of the humerus is disrupted. This leads to the avascular necrosis, leading to the damage of your shoulder joint, and this leads to the destruction of the whole shoulder itself, leaving behind dead bone. Next is fractures, dislocations, and separations. Fractures are breaking your bone. This happens usually in sports injuries, but can be caused by car accidents as well. Other causes that are not injury related are low bone density and osteoporosis. Also, overuse can cause stress fractures. Next is dislocations. This usually happens in older adults, especially women, because they're more prone to fall. A dislocation is when the ball pops out of your socket and could lead to partially or fully dislocation. And then next is separations. This is not a true shoulder joint injury because it involves the AC joint. The AC joint is where the clavicle meets the highest point of the shoulder blade. Common injury of separations is falls. This injures the ligaments around the AC joint. If severe enough, it can cause separation from the collarbone and shoulder blade. Separation usually ranges from a mild sprain to a full separation. And then lastly, for these injuries, surgery or non-surgical procedures will be required depending on the size of the injury or what type of injury you have. And then next, I will be getting into the present and future implications of the degenerative and impingement injuries. How it could affect daily activities if it is left untreated for a long time, or depending on the type of tear you have, this can lead to a complete torn tendon, and then surgery will be required after this. And then how it affects daily activities, your range of motion of your shoulder will be inhibited, or you could not have any range of motion at all. Overhead lifting and reaching will be affected. You will not be able to reach in the cabinets or comb your hair or just reach your arms straight out. Your shoulder strength will be weakened. You probably will not be lifting anything during this time. And then simple tasks such as combing your hair, and lifting your arms straight out is affected as well. These daily activities are not just easy anymore. They could further your healing, and it could end up damaging the joint more if you continue to repetitively do them. Risk factors leading to these injuries, degenerative impingement injuries, they are mostly caused by wear and tear of daily living. Aging plays a big role. People over the 40 have increased risk over time. Repetitive lifting and overhead activities increase your chance of injury. And then sports such as baseball and tennis have the most rotator cuff injuries in sports. And then next is future effects over time of degenerative injuries is that repetitive stress of the same shoulder motion stress the rotator cuff. Next is the lack of blood supply. This is mostly due to age because it is the body's natural ability to repair damage. And then bone spurs. Bone spurs are bone overgrowth, which develops on the underside of the shoulder blade. When we lift our arms, the spurs rub the rotator cuff tendon, and this leads to shoulder impingement. And then environmental and other factors affecting the rotator cuff is also that you can re-tear it after you have it surgically repaired. Also, if you have diabetes, this increases the chance even more, and this also increases the tear size as well. You will have reduced tendon length from surgery, and then body mass index also plays a big role. Dyslipidemia, which is excessive fatty lipids in your bloodstream, and then occupation ratio, and then the fatty infiltration of your infraspinatus are risk factors as well. And then vascular changes, your age, your sex, genetics, tensile forces, environmental factors, the sports you play and the work you do, and smoking and other medical comorbidities are also factors. And then next is injury prevention and training. The type of training that best suits in better control over your rotator cuff is eccentric training. This contraction consists of the contraction for controlling the load while the muscle and tendon are still stretching. This treatment is widely advocated for tendinopathy. Eccentric exercises expose the tendon to greater loads rather than concentric training does, because these are the best exercises for strengthening the tendon. The muscles that you should be targeting to train are the traps, rhomboids, teres muscles, supraspinatus, infraspinatus, subscapularis, your biceps and triceps. Stretches that you should be doing is the crossover arm stretch, passive internal rotation, passive external rotation, sleeper stretch, standing row with the band, and then the pendulum. The range of motion that you should strive to get for your stretches is 180 degrees for flexion and abduction, and 90 degrees for external rotation. And then next is a new approach for shoulder joint research. It's the ADCAP study, which is a new approach to shoulder pain. The most recent study in the field that I could find over shoulder joint research is a study of gene expression and molecular pathways and painful conditions of the shoulder. This study hopes to improve the quality of life and treatments and outcomes for people with shoulder injuries. The doctors use in this study adhesive capsulitis biomarkers to study gene expression and alterations. Also, the doctor uses in this study is biobanking, which is a large collection of tissue samples to answer the questions for the cause and skeletal conditions. And then in this picture that I have shown is it's an arthroscopic surgery over adhesive capsulitis. You can also tell that there's inflammation in it. And then the next picture is the doctor has biobanking. It's blood and urine samples that use to detect biomarkers for adhesive capsulitis. And then lastly is my references. This is what I use to find the research that I have. And thank you guys for your time. This concludes our presentation.